Okay. Hi, everyone. I'm Doug Rex. I'm one of the senior gastroenterologists here at IU, and thanks for joining us and appreciate your interest in colorectal cancer prevention. My expertise is really in colonoscopy and in colorectal cancer screening. I've been involved in national guidelines for a long time on how to prevent colorectal cancer. I've written the screening guidelines for the U.S. Multi-Society Task Force and the American College of Gastroenterology, as well as the quality recommendations about how to perform a very high quality colonoscopy. So my expertise is really in the prevention of colorectal cancer, but managing the whole process of prevention as well as treatment requires a team of healthcare specialists. So we also have the oncologists who are experts in the treatment of advanced colorectal cancer, the administration of chemotherapy, and of course the surgeons, especially our colorectal surgeons, who play a very important part in the management of established colorectal cancer, as well as sometimes we need the help of the radiation oncologists, particularly when patients have advanced rectal cancer, locally advanced rectal cancer. These patients are often treated with radiation therapy prior to surgery. So it's really a team of people that are involved. And my particular, area of expertise, again, is on the front side of that, is how to prevent colorectal cancer from occurring. So my younger partner, John Guardiola, who has kind of the same interests that I do, is the plan was for him to ask some questions that he pulled out of questions from our audience that we thought were relevant, but he's actually involved in a case right now, and so he can't join us. And so I'm going to go through some of this material myself, and we'll be watching also for your questions as they arise during the presentation. So the first one is, what is the burden of colorectal cancer? How big a deal is this? And the answer is that it's a very big deal. It's actually the third leading cause of cancer death in both men and women in the United States. But unlike prostate cancer and breast cancer, it affects both sexes. Breast cancer can rarely affect men, but for the most part, of course, a disease of women. Colorectal cancer affects both. And that's, I think, an important thing to know, that men and women are both affected. And so we actually are making a big impact on colorectal cancer. If you look at the incidence of the disease, which is the number of cases that occur per, for example, 100,000 people in the population, it's been going down pretty steadily, especially in people that are over the age of 50. But the number of people that can get colorectal cancer who are getting older is going up, so that even though the incidence has been falling, the total number of cases is staying about the same. And because it affects both sexes, it actually is the second leading cause of cancer death. And we have more than 50,000 deaths from colorectal cancer yearly in the US, and we have about 150,000 new cases. So it's a very substantial disease. And so another question is, why do we screen for it? Why do we screen for it? Well, first of all, what is screening? It has a very specific definition, which means looking for colorectal cancer or looking for the precursor of colorectal cancer in people who have virtually no symptoms. So if you develop symptoms and you need to get a colonoscopy, for example, that's a different scenario than that of screening. And likewise, screening doesn't really apply to people who have had previous cancer or have had previous precancerous polyps. We call that surveillance. So screening is the whole process of getting people who don't have any symptoms to get checked in some way. And the reason that we do it is, first of all, it's very common, and secondly, it's fatal, but it's also very preventable. And that's because it arises in this precursor that we call a colorectal polyp. So if we can identify colorectal polyps and we remove them, then we basically eliminate the chance of them turning into cancer. It's like having a mole on your skin that the dermatologist says, I don't like the looks of that. Let's take that off because it might do something bad someday. Pretty much the same concept as a colon polyp that is precancerous. It's a growth on the inner lining of the colon that has the potential to turn into cancer. So if we can find it, take it out, we can prevent the process from ever taking place in the first place. So it's probably very rare that cancers arise in the absence of polyps. Now, another question is, are there things that you can do other than screening to prevent polyps from occurring? And there are certainly, because there are some risk factors for developing polyps. They're the same ones that are the risk factors for cancer because it's polyps that turn into cancer. So the most important risk factor is just age. And, as we get older, we develop a risk of colorectal cancer, even if we don't have any special risk factors. But there are some things that create increased risks. So one of them is cigarette smoking. Cigarette smoking is a very important risk factor for a variety of cancers. And we all think about lung cancer, but there are some other cancers that are associated with it, and colon cancer is one of them. So smoking is an important risk factor. Alcohol ingestion may be a risk factor, but it's not as important as smoking. Obesity and diabetes, metabolic syndrome, all of these are associated with an increased risk of developing polyps and cancer. And then there's pretty clear evidence that people who maintain a normal body weight, who exercise regularly, and who are taking certain medications chronically. So the one that's discussed most often, and actually the one that has the greatest impact, is aspirin. So if you're taking aspirin, even a baby dose of aspirin, 81 milligrams, for a matter of 5 to 10 years, your risk of developing polyps and cancer goes down by something in the range of a third. The same is true for other NSAIDs. So things like the long-term use of Advil, Aleve, all that, those kinds of medications, what we call nonsteroidal anti-inflammatory drugs, these also are associated with about a reduction in a third of the risk. Now, these medications have become a bit more controversial as to whether or not to take them to prevent colon cancer, because there aren't as many other clear health benefits as people used to thought. And so some of the cardiovascular benefits of taking long-term aspirin, the recent evidence has kind of undermined the benefits associated with that. So since you're not getting other benefits, we've placed a little bit less emphasis on that, but we still occasionally take people with very high risk and we'll put them on a low dose of aspirin to sort of help reduce their risk. So those are some of the things that can increase the risk or can decrease the risk. But I think that the most important thing to remember is that if you hit a certain age, you have developed risk, even if you're leading a very healthy lifestyle. And the second thing is that polyps and even early cancers don't cause symptoms. So there's a very strong tendency for some people to think, I don't have any trouble with my bowel movements. I'm not having any trouble, using the toilet. I'm very regular. I'm not having diarrhea or constipation. I don't see any blood. And so, I should be fine. Well, that is not true. That is probably the most important thing to recognize, is that you're at risk even if you have no symptoms. And polyps, before they turn into cancer, just generally almost never cause symptoms. Only a tiny fraction of them cause any symptoms. And even early cancers very frequently don't cause symptoms. So good to know about these risk factors, but don't place too much emphasis on it, because you hit the right age, you're at risk. Another question is, what are the symptoms? And again, this gets away from the idea of screening. So when we talk about symptomatic patients, this is often people who have established cancer. And here, the most important risk factor is bleeding. So we tend to take the symptom of passing blood into the toilet seriously. We have real concerns about that. You hear about other symptoms such as a change in the shape of the stool, a change in bowel habits, the development of abdominal pain. And I'll just say in general, if there's no bleeding at all, then those symptoms have much less predictive value for the presence of cancer. Of course, a lot of people that have rectal bleeding don't have don't have cancer. There's a lot of bleeding from hemorrhoids, other causes around the anal area. But the risk of cancer is greater in people that have bleeding. We take that symptom most importantly. Now, I also want to say that a really tricky part of what's going on right now is that we've lowered the screening age from 50 to 45, but there are people that develop colon cancer before the age of 45, and we don't screen. So there, we have to rely to make the diagnosis on the aggressive evaluation of symptoms. So in people under 45 who are having rectal bleeding, we like to take that symptom very seriously and frequently do a colonoscopy or at least a partial examination of the colon. Excuse me, I'm looking over here at the list of questions. Okay. So the question is, what happens if you're diagnosed with colon cancer? Well, when we diagnose a colon cancer, the first thing that we want to know about is, what does the CT scan show? We're going to get a CT scan of the abdomen, the pelvis, and the chest, and we're all holding our breath to know whether or not there has been spread of the cancer to a distant site. And the most common one is the liver, but there also could be the lung or other solid structures in the abdomen. If that's happened, then unfortunately, oftentimes the eventual outcome may not be good, but the oncologists still have a lot to offer patients who have cancer that has spread. So the first thing is we do what we call staging. In the case of rectal cancer, that also often involves an MRI. And if there's actual established cancer, many times, if there's no spread, then the next step is going to be surgery. The stages are there's different staging methods, but stage one, which is just in the wall and not yet into the muscle. Stage two, which is into the muscle layer of the colon. The colon has layers to the wall. Stage three, generally it's spread to the lymph nodes. And then stage four, there's distant spread. So stage two is usually treated mostly by surgery. Stage three, then sometimes what we call adjuvant chemotherapy comes into play. And this has a great benefit in patients who have stage three disease. And then stage four, some of them can still be treated surgically. Depends on how much spread there is. Sometimes they're going to receive more of a palliative types of treatment, usually chemotherapy. But that's kind of what happens if folks are diagnosed. Okay. So obviously we want to try to avoid all that. We want to try to stay in the whole mode of trying to prevent this disease, and that involves screenings. Okay, so who should get screened? Well, we recently lowered the recommended age to begin screening from 50 years to 45 years. And so why did that happen? It's because there has been, I mentioned before that the risk of colon cancer in people over the age of 50 has been progressively declining, actually for several decades. But it's been going up in people who are currently under the age of about 50 to 55 years. So a trend started in people who were born in the 1970s and afterwards. And whatever is going on seems to be increasing in trajectory. So if you look at people who are currently in their 40s and compare them to people who are in their 40s, 50 years ago, their risk has risen substantially. People in their 30s right now don't have as much risk as people in their 40s. But if you look at their risk compared to people who are in their 30s about 50 years ago, it's gone up even more than people who are currently in their 40s have gone up compared to a long time ago. So the impact of this is increasing. And the question is, why? What is going on? And recently, we've seen evidence that this is happening not only for colon cancer, but for some other cancers, that young people, the risk of cancer is going up. So there, as you might imagine, huge amounts of research going on to try to sort this. And the leading candidates for this are And I will say that these are not mutually exclusive or listed in the order of importance because we don't know. But one of them would be the introduction of processed foods on a large scale into our diets in the 1970s, the increase in obesity that has been occurring. There may be some changes associated with antibiotic use, for example, during childhood, that have led to a change in what we call the microbiome, or the type of bacteria that are present in the colon. There have been studies showing that the more sugary drinks you had when you were a teenager, the greater your risk of colon cancer. Your mother's weight when you were in utero, the heavier your mother was, the greater the risk you have of developing colon cancer. So lots of associations are being drawn, and I think are not completely understood. But there's no question that the effect is occurring. We used to say that about 7% of all colon cancers occurred in people under the age of 50, and now we know that that's doubled up to 15% of all colon cancers. And in terms of all these cancers that are occurring in people under the age of 50, if we lower the screening age to 45, we can catch about half of them. The other half are in people under the age of 45. And there again, we don't screen unless there are special other risk factors. So what are those other risk factors that might make us do that? Well, the one that is used in clinical practice is the family history of colon cancer. So when we take a family history, we focus on the actual diagnosis of either colon cancer or what we call an advanced adenoma. It's a polyp that was bigger or had some other features that made it closer to cancer. And first degree relatives means your parents, siblings, and children, as opposed to your aunts and uncles and cousins and so on. So the second degree relatives, those are not considered as important. So we focus on the first degree relatives. Second degree relatives are important primarily when first degree relatives are also affected. But if you only have a cousin or someone who had colon cancer, it doesn't create that much risk for you. The other thing that's important is the age of the first degree relatives. And the first degree relative is usually a parent, but we use a cutoff of 60. So if your mom or dad had colon cancer at 70 or 80, we recommend that you start screening actually at age 40, but we don't think you have to get checked any more often than anyone else. So you could have a colonoscopy at age 40, and if it's normal, what we usually say in people who with no family history is you can wait 10 years before you have another one. And we would do that with that low risk family history, a parent diagnosed at an older age. If they were diagnosed under the age of 60, or if you have 2 or more first degree relatives, then we recommend colonoscopy every 5 years. So genetics do come into play in that setting. There are questions about how to screen for colon cancer, and I will tell you that there are a variety of tests that have been recommended, but I want to focus on what's most commonly used and tell you a little bit about the benefits and the downsides. So in the United States, I'll say first of all that colorectal cancer screening still in many parts of the country is dominated by colonoscopy, and this has developed over the last couple of decades. And the reason is that colonoscopy is by far and away the best test at finding these polyps. And that's the reason why colonoscopy only has to be done every 10 years. And I will tell you that probably we'll see recommendations made in the next few years that you could have a colonoscopy even every 15 years. We might see it every 20 years. And the reason for that is that colonoscopy is getting better and better at exposing all of the lining of the colon and seeing even the flattest little lesions. We know that when you're normal, you're really normal, and consequently, you're going to be protected for a long period of time. So that's why colonoscopy, I think, is still the most popular. But we have a problem with colon cancer screening, and that is that a very significant fraction of our population who should have been screened is not up to date with screening. It's about a third. And that is higher than the rate for breast cancer screening and for example, cervical cancer screening And the reason that people are bothered by that is that colon cancer screening is actually more effective in preventing cancer than mammography is for breast cancer, or that, cervical cancer screening is. And so it's very effective, but there's some hesitancy about getting screened for a variety of different reasons. And so it is important that we have other ways to get people screened besides colonoscopy. And the two popular ways right now are both stool tests. And the one that everybody hears about is this test called Cologuard, which is made by Exact Sciences, which is an American company. Now, this we are the only country in the world that is sort of embracing Cologuard. The rest of the world thinks it's too expensive to use as a screening test, but it has a number of advantages to it. One is it's actually quite good at finding cancer. It's not nearly as good as colonoscopy for finding polyps, but it's better than the other stool test, which is the stool test for blood, what's called the fecal immunochemical test. So it's got a fair number of false positives to it. If you use one of these stool tests, it's very important to know that if it's positive, the proper response is to have a colonoscopy. If you have one of these tests and you have a positive test and you don't go get a colonoscopy, then nothing useful has happened, because the only way we can actually find the polyps, get them out, make sure there's not cancer, is by going to colonoscopy. So you might consider a stool test to be a two-step test, because the first step is the stool test. The second one, if it's positive, you go on to colonoscopy. Because these tests are not as good at finding polyps, they're recommended more often. So the Cologuard should be done every 3 years. And if you rely on just the fecal immunochemical test for blood, it should be done every year. Although I'll say there are a lot of countries now that think it can be done every 2 years. And if you look at countries that have what we call organized screening programs, or even in the United States, there are healthcare systems that do this. The best example is Kaiser in California. They actually rely on that stool test just for blood because it's very inexpensive. And they actually mail out, these stool test kits to everybody in the healthcare plan that's eligible every year. And they have navigators and they think that that's the most cost-effective way to do colorectal cancer screening. Turns out it's very hard to do it for a private doctor's office that's trying to do it by themselves to keep up with their patient pool, mailing these things out. And that's one of the attractions of colonoscopy. And that's one of the attractions of Cologuard, is that you only have to do it every 3 years instead of every year. I think another thing that people like about Cologuard is that the company that, markets it also navigates it. So they send the box right to your door. The sample is collected. It's shipped back to them. If it's positive, they start getting on you to get your colonoscopy scheduled. So they do a good job of taking care of a lot of things that sort of are around this process. And those are our main options. Some of you may have heard about blood tests. Blood tests are coming for colon cancer. We've actually had one on the market already. And they're going to be decent tests for finding cancer, but they are not going to be effective tests, at least the first ones, for finding polyps. So they're going to be very expensive. They may have to be done every year or so. And so it's hard to know right now how the blood test thing is going to work out. Everybody would like to find a blood test that had kind of acceptable performance, but so it's not totally clear how that's going to pan out. But if you think prevention, finding polyps and take them out so you can't get cancer in the first place, is a good concept, I think that's a great concept, then the blood tests are not looking very good in that regard right now. And then the next test is, what does a colonoscopy involve? I'm sure many of you have been through a colonoscopy. So the worst part of colonoscopy, everybody would agree, is the bowel preparation. And that's a part of nobody likes because you have to get cleaned out for the doctor to have a good examination. And this is really a place where the doctor's office and the patient are kind of in a collaborative thing to make sure that you get an effective prep. So the key things about getting effective prep are you need to take part of it on the day of the colonoscopy. You can't just take it all the night before, because if you do that, the prep will clean all of the fecal material out, but then pretty quickly mucus starts to build up in the colon, and that mucus can be very sticky and it can prevent the doctor from seeing well during the colonoscopy. So we like at least half or even all of the prep to be taken on the morning of the procedure. So if you're scheduled at 7 o'clock in the morning, you've got to get up, and take part of it, maybe 2 o'clock or 3 o'clock in the morning to get a really high quality prep. And you want that because if the doctor feels confident that they got a good exam, they're going to say to come back in 10 years. There are a variety of options for prep. And one question is, what's the easiest prep to tolerate? And um, I think the general conclusion from the literature, there's a lot of studies done on bowel prep, is that a prep that has a lower volume of active ingredient creates the best experience, is best tolerated, leads to the best willingness to have another colonoscopy. So the big jug of 4 liters, that tends to be the one people have a hard time finishing. If you can't finish it, then the prep quality might be compromised. So better to have one of these preps. And there's one prep where you only have to drink, like 1 liter of active, something that tastes not so good. And of course, there's a tablet preparation. So why don't we just like give the tablets to everybody? Or why don't we just give the low volume things to everybody? Well, sometimes there are issues with the person's health status, their kidney function, or their cardiac or function, or if they have really severe liver disease, where certain preps, are not quite as safe as some of the other preps. And then the other part that comes up all the time is how well does your insurance cover the prep? Because some of the preps that have not gone off patent are more expensive. A lot of times there's some kind of a voucher program that even if the prep costs over $100, you may be able to get the prep for $40 or $50. So you have to, I think, get actively involved. In our practice, we have 5 different preps that are available because, sometimes it seems like people will take one, they say they don't like that. They have another one, they don't like that. So we have options to go to. So if you're concerned about that, if you've had a bad experience, it's worth actually talking to the doctor and trying to, find out what your options are and what things may cost. After that, you're going to go and have a colonoscopy. The procedure itself is typically very safe and easy. The sedation, people usually receive sedation. It's interesting, you don't have to. We have some patients, often they're doctors, they want to come in, have their colonoscopy, go back to work, and they ask for it unsedated. And in general, people that are motivated to do that can have a colonoscopy unsedated. Most people just want to know nothing about it, and that is available. And so the procedure itself is usually very well tolerated, and in general, it's very safe. It's good to have somebody who is experienced. If you're asking yourself like, what do you want to try to find in the doctor who's going to do your colonoscopy? I mean, do I want somebody who is a man or a woman? Do I want somebody who's whatever the choice is, tall, short, good looking or not? What you really want to know is what's called their adenoma detection rate. Do they measure their adenoma detection rate, and is it really high? A good number is above 40%, but this is a reflection of how careful they are, because colonoscopy is an operator-dependent procedure. Some people are really good at it, and some people aren't. And so it's hard. It's good to get some hard information if you can, or to ask around about that. And there's some questions about, for example, when can you stop screening? Um, when people have gone past 75 and they have never had polyps, we often will stop the process of screening. And the recommendation is to stop screening entirely after age 85. Whether or not to stop is, first of all, you have to keep in mind, are you talking really about screening, or are you talking about surveillance? Surveillance is people who have had previous polyps or cancer. So all the time, surveillance patients are asking us, I'm 75, can I stop now? Well, if you've had a whole bunch of polyps or serious polyps or colon cancer and you're 75 and you're still healthy, half of people that get colon cancer get it after the age of 73. So, stopping surveillance, people have had polyps, is different than when to stop screening. And I think in general, it's a function of a person's age, but also their what we call their comorbidities, their health status. What is their life expectancy? And then what's their polyp history? If you've had a lot of polyps or serious polyps, then and it looks like you're going to live for another 10 or 15 years, it may be appropriate to continue with surveillance colonoscopy. There's a question here about what are some common misperceptions about colon cancer screening and colon cancer, and how do you address them? I think one of the common misconceptions is that it's a disease of men, and that women are not affected, and that is not true. It is true that at any given age, like say if you look at 60-year-old men and compare them to 60-year-old women, 60-year-old men are at slightly increased risk. If you look at who gets the most cancers over the course of their lifetime, it's actually women. And so women live longer in part so they live long enough to catch up in terms of total numbers of cancers. But there also is an effect that's associated with menopause. So in the premenopausal era, some of the hormones that are associated with that, higher estrogen levels, are associated with some reduction in risk. So postmenopausal women who don't have that same level of estrogen, their risk of colon cancer rises with time. So that's one of the misconceptions. I think a very common misconception is one that I alluded to earlier, which is people not acknowledging that they are at risk and not taking the time to get checked. And certainly you want to get checked very promptly if you have symptoms. And if you don't, you want to make time in your schedule for getting screening done, and be sure to talk to your doctor about it. I think doctors sometimes, primary care doctors, it's been shown a lot of times patients either say that they haven't been advised to undergo screening, or at least they don't remember being advised. And if you have that occasional wellness visit, maybe the annual wellness visit, that's a good time to ask about, are you up to date with things like screening tests? Are you up to date with vaccines? But remember to ask about colon cancer screening also. And if you're at the right age and your primary care doctor says, I don't think you need to do that, well, that's the wrong advice. So you need to ask further. You need to push for it, or figure out another way to get screened. So let's see. There are some questions again about hormonal therapy, and it is true that hormone replacement in postmenopausal women is associated with some reduction in risk of colon cancer. But there are so many other risks associated with it that nobody is prescribed, hormonal replacement for the purpose of preventing colon cancer. So That's the answer to that. And I think that have I think I've covered most of the questions that have been listed here by John. So if there are any other questions, I think perhaps that we can bring the meeting to a close. Good. So I'm getting message that we don't have any other questions right now. So I appreciate your interest in colon cancer. I hope that you'll uh, get screened yourself if you should be. If not, please encourage your loved ones to get screened. And thanks very much for listening to the program. Appreciate it. Thank you.